Welcome to the Industrial Athletic Trainer Society On-Demand Continuing Education Program. In this session, you'll gain practical, evidence-informed insights designed to enhance your effectiveness as an industrial athletic trainer and support the health, safety, and performance of the working population. If you find this video valuable, be sure to like, comment, and subscribe to stay connected with future content from the Industrial Athletic Trainer Society. Society members, once you have viewed this video, stick around at the end for instructions on how to claim your CEU. We hope you enjoy the content. Let's get started.
Here with the Industrial Athletic Training Society, and I am really excited to have a session here today presented by Susan about staying frosty, right? So we're going to look at protocols and cold injury prevention programming. So real quick, Susan is gracious enough to lead this call today. She is a graduate from Radford University with a bachelor's in athletic training and the University of Alabama at Birmingham with a master's in engineering in advanced safety engineering management. She has over a decade of experience in industrial athletic training and worked in various disciplines and a variety of laborers from delivery drivers to welders in construction and a variety of environments with extreme hot and extreme cold. So we're really excited. She's also our president of the Industrial Athletic Training Society. So shout out to you. Thank you for everything that you do. Thank you again for being here today. I will go ahead and monitor the chat for anybody, and then I will have some information here at the end. So I turn it over to you and let me know if you need anything.
Awesome. Well, thank you, Mike, for that wonderful introduction. It said over a year. I don't know if that was a typo on my part, or over a decade. I'm at almost a decade. I think I'm 8.5 years. So that's exciting. Making my way up that YP ladder. Okay. Eventually I will cross over. I think it's 12 years or something. It's a really long time for athletic training, but I'll get there. But yeah, so Mike shared a bit of my background. One area that I definitely enjoyed in the industrial setting has been, really being able to specialize in exposure to the elements, mostly heat, but also cold. I've had the experience of working with workers who work outdoors in both climates, so extreme cold and extreme heat. Today, we're going to be focusing on the extreme cold side of things, of course, and just sharing some awesome information that hopefully is very valuable. So, bit of a disclosure. Again, this presentation is intended for educational purposes only. It is based on current research. Really enjoyed the research that I was able to do preparing this program for you guys. And it has a bit of my professional expertise in it as well, of course, but definitely do your due diligence, and it doesn't substitute, of course, the education we have and the things you've learned that may be more specifically applicable to your area. But there are no conflicts of interest here. Everything is just that I talk about is just based off of the research that I have. There really isn't any product even mentioned, I don't think, if I recall correctly. But yeah, just hopefully this is something that you can take with you and apply to your practice, and it will help you do better for your patient populations. So for our objectives today, hopefully you come away with at minimum these 3 things. I think you'll come away with a lot more than that. But at the end of this learning session, you'll be able to apply administrative controls and essential personal safety measures to support the prevention of cold and cold-related injuries. You will also be able to differentiate between the severity of common cold injuries, including hypothermia, frostbite, frostnip, and a couple of the other ones we'll talk about. And then you'll be able to execute field management protocols for cold injuries that are in line with current guidelines and best practices. So I think there's a lot of really good information here for us, especially because this is probably an area we don't cover as often or as much, mostly because, and as we'll see in a second, we consider our people are kind of generally on the lower end of risk, but you never know when these things can happen, especially if you work with outdoor workers, utility workers, construction workers, even some of your delivery workers, whether it's package delivery, trash pickup, or some of those city services, postal workers, and so on. There are a lot of our workers who spend their time exposed to cold. people can also incidentally be exposed to cold on their way to work, which can lead them to experiencing some of these things that we're going to talk about. And then on top of that, how many of us experience more injuries in general during the winter months as a result of slips, trips, and falls, and so on. So still a really good topic to discuss, even if it's one that we may not encounter as often. This would be a really good refresher, and hopefully you learned something new. So here is kind of our table of contents, our agenda for the day. We're going to just briefly go over just some basic info that everyone should know. These are just foundational competencies when it comes to understanding cold. And then we are going to dig into hypothermia, because maybe that's why a lot of you are here. And we're going to really talk about, the different severity levels and how hypothermia presents, just some best practices. And then we're going to discuss field management, ensuring that you know what to do in the event of a hypothermic patient, and that you're able to communicate these protocols to your stakeholders, to your safety team, maybe the rest of your healthcare team, and just ensure that everyone knows, how to manage these cases if they pop up. And then we're going to talk a bit about localized cold injuries, predominantly frostbite, of course, which I'm sure is another reason why some of you tuned in today. And then we'll talk a little bit about prevention and mitigation, which is pretty basic, avoid the cold. And then we'll wrap it up with some Q&A, okay? So let's get into our foundation, okay? So for those of us who may remember our numbers from the Heat IQ that we did this past summer, the 3-part series that we did talking about heat illness, if you remember any of those numbers, you might be kind of looking at some of these charts here and saying, wow, these numbers are a lot lower, right? Which is definitely true. Cold injuries and cold environment exposure, fatalities and injuries are less than heat hazard injuries or fatalities. That just is what it is. Still though, especially when you look US-wise, country-wise, it is pretty significant. So they estimate 7,000 to 1,500 hypothermia-related fatalities reported in the US each year. Now that is a pretty broad range, but still a pretty significant number. When it comes to work-related, you can kind of see here fatal work injuries by kind of your atmospheric conditions, right? So these are any weather-related deaths. So if you kind of look at the ice, sleet, and snow segment of this, we're looking at about 20-something as currently reported by the Bureau of Labor Statistics. Leading up to 2020, wasn't really able to find much information beyond that. And you'll also kind of see that what they are considering a death from weather and atmospheric conditions is not always going to be cold. So included here typically were fatalities from, as the primary source, if you look at this graph on the right, especially in 2020, I think those 3 injuries that it was the primary source were lightning, right? Lightning strikes. So that makes a lot of sense. When we break down the secondary source, that's where you're going to see ice, sleet, snow kind of come in and take up a big section of being that secondary cause when it comes to a fatal work injury. So again, still a present hazard, and so worth kind of learning a little bit about and seeing what we should do. So where does this responsibility, for preventing workers from cold injuries fall under? Of course, very much like heat, our general duty clause, right? So cold injuries in the industrial setting, again, don't get much recognition because the numbers are kind of low, but we do still have an ethical responsibility and a legal expectation to protect these workers on the safety end, for those of you who are kind of more on the safety end of work, or if that's kind of how you're communicating to your safety team, they should understand that this is still considered a hazard that employers are required to address when it comes to their workers. And again, injuries. So When I was kind of doing my research, they estimate about 20,000 worker injuries annually, kind of as a result of cold. So when you think direct and indirect costs, that can be significant. A lot of that being due to slips, trips, and falls, right? Due to poor maintenance of ice, snow, sleet, maintaining the workplace, parking lots, entryways, and things like that. So hopefully each of your employers recognize that this is something they're responsible for. But if they don't, maybe this will give you a way to kind of frame why they should care. So another important foundational aspect is going to be our risk factors, right? When it comes to our intrinsic risk factors, when we're looking at who's going to be more susceptible to cold and cold injuries, both our very young and our very old are going to be at increased risk. So small children, right? Not so much our teenagers or more adults that we see, and then your frail or your kind of more geriatric patient groups are going to be at an increased risk. Malnutrition is a serious risk for hypothermia. So as we get into the pathology of hypothermia, we're going to see that it takes a lot of calories for your body to warm you. And lack of nutrition and things like fatigue can significantly hinder your body's ability to respond to cold weather. So for those of us who don't know, our body acclimates to heat a lot quicker and easier and better than it acclimates to cold, because it's a lot easier for our body to lose heat than it is to retain heat. Think of our skin. Our skin is very good at offing heat. Maintaining heat or keeping heat stores or preventing heat loss is much harder of a task, and it takes a lot of energy. It takes a lot of sugar. So we're going to see that later down the road. And then chronic illnesses, so diabetes, again, specifically hypoglycemia, your people who have a tendency to drop low, they're going to find themselves at risk because, again, warming yourself takes a lot of energy. You'll even see COPD, they've been documented to have an increased risk. Those with chronic skin disorders, so psoriasis, burns, these have been found to be a risk factor of cold and cold injuries. And then certain medications and drugs. So things like beta blockers, antidepressants, chemotherapy drugs is another big one. These can increase the feeling of cold. And also they find that hypothermia can be secondary from drugs like general anesthetics, beta blockers, Demerol, clonidine, neuroleptics. Alcohol use is another big one. So those are all things to consider when we're looking at risk in our populations. And then we have some of our extrinsic factors. So fatigue is a big one. Decreases the shivering response. That is your body's way of warming you up. One thing we're going to talk about is shivering actually increases your heat retention or heat production by like 5 times versus if you were not shivering. So being fatigued can inhibit that, which is going to make it difficult for your body to keep you warm. Dehydration applies in the heat and in the cold. We always want our workers hydrated. With this one, it is going to lower that blood volume, right? Which is going to inhibit your core temperature regulation, especially when you start to vasoconstrict. You'll have even less of that peripheral flow due to decreased blood volume. So being hydrated means more blood volume. Your body has more blood to move around and warm you and keep especially our extremities warm. So dehydration can be an extrinsic factor. And great call out there, Mike, with nicotine also is a drug that can make a difference. So that's just a little bit of a general foundation on what we're looking at when it comes to risk factors. So the last thing we're going to talk about and kind of building our foundation is going to be this wind chill factor. Wind chill factor is kind of parallel to your wet bulb when it comes to The true feeling of cold, just like the wet bulb kind of is your true, like how hot you're feeling, how well can your body cool you down in the heat. Wind chill factor is telling you how cold do you actually feel. And what it's doing is it is incorporating the effect of cold wind on your exposed skin, because that is where you're going to lose a lot of your heat, is from that exposed skin. So wind chill factor is again measuring how quickly does the body lose heat. It is not the same as your thermometer reading of the same number, okay? So as an example here, let's say that our thermometer is telling us it is 40 degrees Fahrenheit, and the wind speed is 20 miles an hour. If we look over at our chart here, that is telling us that our wind chill is 30 degrees Fahrenheit. Now, important thing to note, when you incorporate your wind chill factor, that is going to tell you that you are going to lose heat more quickly, increasing your susceptibility for hypothermia. What it will not do, though, is cool your body down the actual air temperature. So what would that tell me about this example we're working with here? If you're outside due to these winds, let's even say the wind was going 50 miles an hour, right? And so now your wind chill is 26. Again, 30 was already a big risk. Now it's even worse. Your exposure or your potential for hypothermia will continue to increase as the wind goes faster and, you know, blows faster and faster. What's not going to increase is your susceptibility to frostbite, because even if your wind chill is 30 degrees Fahrenheit, 26 degrees Fahrenheit, 25 degrees Fahrenheit, your skin cannot cool below 40 degrees, because that's the actual ambient temperature, which means that your skin will not develop ice crystals, will not freeze, will not do the process that is necessary to expose you to frostbite. So hopefully that's kind of making sense. Now, obviously, if the temperature is 20 degrees and then we have a wind chill, you know, the wind's blowing 20 miles an hour, now we're dealing with a wind chill of 4 degrees, this person is going to be susceptible to hypothermia, frostbite, frostnip, all of it, right? But if your ambient temperature is not at freezing point, wind chill cannot cool you down below freezing. You will get cold, but we know that hypothermia, by the time you hit 95, I mean, you're already in your hypothermic range, but it cannot bring you below 32 degrees Fahrenheit because the outdoor temperature is not that cold. So hopefully that makes sense. If you have any questions about that, definitely ask, but that is wind chill factor explained. So those are going to be your main foundations. Again, just some numbers on cold weather, and then what our risk factors are we're looking at, and then again explaining this concept of wind chill. So let's get into one of the big reasons we're gathered here, which is to discuss hypothermia. Okay, so what is hypothermia? Hypothermia is, sorry guys, one second. I'm just going to my laptop that it's on battery saver. So let's plug her in. We're plugged in. Okay. So hypothermia is defined as a drop in core body temperature below 95 degrees Fahrenheit. This occurs when your body is losing more heat than it is able to absorb or create. This results in a failure to maintain homeostasis and proper bodily function, very similar like we see in hyperthermia. Hypothermia affects all organ systems and is potentially fatal if not properly treated. So we know maintaining an ideal temperature is critical to our body being able to function properly. In hypothermia, you're going to see a lot of the things you see when the body is not able to maintain homeostasis. And it's going to come with a lot of those neurological symptoms that we're already pretty accustomed to, just that our mechanism is going to be different, right? So hypothermia is lumped into 3 main categories. So this is not really something you see with hyperthermia, right? Or heat stroke. Well, you do have like heat exhaustion and so on. So you could see it that way with hypothermia. So mild hypothermia, this is going to be typically represented by a core temp of 90 to 95. Subtle nonspecific symptoms are going to be what the patient is experiencing here. Hunger, maybe they're feeling fatigued, they're shivering, skin is pale and dry, they're feeling a little bit nauseous, okay? Now what you're gonna see is the body trying to warm itself up. These are going to be your thermogenesis symptoms: increased muscle tone, increased blood pressure, increased heart rate, increased respiration. It is basically doing its job to try and generate heat because it's recognizing, oh, our core temperature is falling outside of the normal range and we're getting into a bit of a dangerous territory. So it is going to be working really hard to warm you up. And that's where some of that hunger and fatigue and so on may come from in the symptoms that someone's feeling. Neurologically here, you may see some memory and judgment lapses or impairment, some cognitive decline, dysarthria. So you might already start to see some of your heart issues coming into play. Again, usually because the body is working to warm you. Cold diuresis is also another potential symptom you'll see. So this is where this person might urinate more frequently. So this basically occurs because your body is vasoconstricting. At this point, it's probably just shunting blood from your microvascular system, right? So our capillaries and arterioles, venules, it's shunting that blood back to the core because it's probably prioritizing keeping your core temperature where it needs to be. This vasoconstriction is then also going to push fluid to your kidneys, which leads to that cold diuresis. So they might find themselves urinating more often. So then we have moderate hypothermia. This is described as a core temperature of 82 to 90 degrees Fahrenheit. Symptoms here are going to be hypotension, bradycardia, how do you guys know what I mean? So the biggest thing you're going to see here is very similar to heat stroke and hyperthermia. Is after your body has kind of tried to compensate, you're going to see where it has now taken that curve where it now begins to slow down because it was not successfully able to reverse course. So that's why you get lower blood pressure, lower heart rate, breathing a little bit slower, all those things coming in. You're going to see cognitive decline for certain. They may be lethargic, hyporeflexia, so those kind of slow responses if you are attempting reflexes on this individual because the body is cooling down, has cooled down significantly at this point, and its response is slowed. Often in these individuals, they will typically not be shivering any longer. Again, part of that kind of slowdown of body response. Paradoxical undressing is going to be a good symptom to know that someone is out of mild hypothermia. So this is where the individual is no longer shivering, thinking that they're too hot. They're going to begin to remove their clothes because they think they're too warm. So that's going to be a good sign. Here's where your susceptibility to some of your dysrhythmias is going to come in, AFib being the most common one. And as we talk about our field response, we'll just talk a little bit more then about the heart and why the heart is very important to protect. So if you go below 82 degrees Fahrenheit, you are now in severe hypothermic range. This person's usually going to be unconscious and everything is going to be low. Blood pressure, heart rate, cardiac output. You may or will likely have dysrhythmias present in these individuals. Pulmonary congestion is another big one. So that fluid in the lungs, no reflexes at all, not urinating and so on. Again, their unconsciousness and finding them in the cold hopefully is able to get you to kind of make that connection a lot faster before you get to some of these other symptoms. And we're going to talk a little bit in our field management about the primary eval and why that's going to be the first focus before we get into addressing these other symptoms. Very likely for these individuals to result in cardiorespiratory failure. And we're going to see that especially for profound hypothermia or severe hypothermia, even with some of the more invasive warming interventions, odds of making a full recovery drop to like 50% and below for these individuals, just because of what it does to the heart and how difficult it is to rewarm these individuals. So there's a little bit about hypothermia. So hopefully, at least if you didn't know those phases before and kind of being able to identify them, this is going to kind of be helpful for you, especially with some of these key symptoms that are going to give you a little bit of introspection into what phase these individuals are in. So let's talk about field management. Again, having a good, clean response to hypothermia is going to be very critical to saving this person's life, because as we're going to see, keeping them in the level they're at and not letting them go further down the scale is going to be really important to increasing their outcomes. So let's talk about the primary survey. If you find an individual who is unconscious, not breathing, I'm sorry, I have a request. Please review paradoxical undressing again. So paradoxical undressing is when someone begins to remove their clothing inappropriately because they are no longer shivering and they think that they're warm. That's just what's going to tell you this person's not in mild hypothermia anymore. Unlikely. They've progressed further along. So they start to feel like they're hot. And so they may start taking off their coat, taking off their gloves, taking off their boots, their socks, things that you would not remove in this circumstance because it's cold out. They will begin to remove their clothing because they actually think that they're hot. That's what that is. Hopefully that helps. If not, we can talk about it more further down. So again, that primary survey, resuscitation is going to be your priority if you find somebody who is not breathing, who does not have a pulse, who is not conscious. So that is just a reminder here. You do not want to get too far into your secondary survey if this person needs to be resuscitated. That is going to be the focus. And unfortunately, as we see with the secondary survey, you typically want to be very careful with these individuals and how you're moving them and how you're handling them, because you want to prevent the heart from going out of whack, for lack of a better term. There is a better term. We'll just talk about it later. But unfortunately, obviously, if somebody has lost the pulse, resuscitation is going to be priority number one. So if you work with a population that may be at risk of hypothermia, definitely want to keep your resuscitation gear at the ready, nearby, have a good process, maybe some of your utility groups that are outside, or workers at way stations and oil and gas, or even like think of your forestry individuals, clear map outline of knowing where AEDs are and things that, will make it easy for someone to have access to be able to resuscitate someone, because not much you can do if you're doing other things and this person is lacking the ABCs. So let's say that they are breathing, even if that breathing is very low and slow. There's circulation, again, even if it's low or slow, a slow pulse, and so on. You're going to go into your secondary assessment. So very similar to hyperthermia, being able to get a core temperature is ideal for your hypothermic patients. And a lot of the research recognizes it is not easy, and it's definitely not always possible. So we're just going to talk really quick about kind of what's recommended when it comes to getting a core temperature from these individuals. So the best one that they recognize generally in the literature is going to be an esophageal core temp. You do need an advanced airway in place to be able to take this, because you're going to take it in the lower third of the esophagus. So obviously, as ATs, especially if we're the first people on scene, we're probably not going to have an advanced airway in place. So it's probably not going to be even an option. Second best is going to be an epitympanic probe. So some of your, if you already have a probe thermometer, it may just have a probe that you can use with the thermometer that you have. What you're typically going to see with these probes is it's like a bit of a shorter probe. I'm realizing maybe a picture would have been helpful here, but you can look it up. Not to be confused with a typical tympanic thermometer, right? Which is the little one you click and like hold it up to their ear or put in their main ear canal. That is not what this is. It is a small probe that goes into the ear. And what you'll often see that tells you that it is this type of thermometer is there's sometimes a piece of foam that's like an inch or 2 inches to the end of the probe. And that piece of foam is there to kind of occlude the ear canal so that you don't get cold air in the ear, that the ambient temperature is not messing up your core temperature. So it'll have this little piece of foam on it that you use you just put the probe in and block the ear with that foam, and the probe is inside and will give you that temperature. Oral, you're typically only going to use oral temperatures to rule out that someone is hypothermic. So they say yes, oral works, but most oral temperatures don't go below like 93 degrees. So you're not going to be able to stage where in hypothermia this person is. You're only going to be able to basically say you don't have hypothermia because you're 96 degrees. So they said, yeah, they're useful, but not really for someone who is actively in hypothermia. So not recommended. Again, the tympanic ones, they just are too susceptible for the ambient temperatures. And right along with the question that Jeremy has here in the chat, rectal and bladder, they just don't recommend those, even though they're usually more available pre-hospital. And the reason for this is that they find that rectal temp lags behind true core temp by about an hour. So that's actually the reason that they don't recommend that for hypothermia. So great question. So again, like I said, it's ideal to take a core temp. It's great, but even if you don't have it, we just went over a lot of the neurological symptoms and behaviors that are going to kind of help you stage where somebody is at. So definitely with these individuals, you want to take a complete history as best you can, because ideally they're conscious. And you're definitely going to be looking for cold exposure, prior traumas, things that can kind of explain what is going on with them. The differential for hypothermia is really long, and I don't know if I had it here in these early slides. I don't believe I did, because I was just kind of focusing on hypothermia and explaining it. But there are a lot of things like hypothyroidism, hypoglycemia. There are a lot of things that in cold weather, someone can be exhibiting a lot of these symptoms, and you may have another cause for why they are lethargic, dropping in and out of consciousness, or feeling the way that they feel. So definitely you want to, oh, I actually just had it right here on the screen. Susan, look alive. So yeah, I have a lot of the things on here for all the other things that could be going on with someone that are not hypothermia, but a lot of this stuff is going to expose someone more to cold injuries anyway, especially malnutrition, alcohol abuse, some of these other things. So still, you want to take a thorough history to kind of help you figure out what is going on with this individual and kind of make your best guess. If someone, you know, is low on your Glasgow Coma scale, if someone is really displaying some of these more severe symptoms, 911 is going to be your call out, obviously. I think as ATs, we're all pretty good at knowing when we need to call emergency, but we're going to kind of talk in our field management about what we can do in the field, okay? Physical exam, again, you're going to try and identify or note that they don't have any local cold injuries, which we'll talk about those later. You're going to want to take your vital signs and symptoms. And again, any red flags that pop up here, we want to refer appropriately. And then we want to remove their clothing, especially if it's cold or wet, and get some warm, dry clothing, blankets, insulation on this individual. Again, very similar to dealing with our heat illnesses. Preventing this person from progressing further down the continuum is very, very important, okay? So when it comes to our field management, besides calling 911, you're really going to focus on two main paths to helping this individual, which is preventing further heat loss and rewarming the individual. So first, preventing further heat loss. Again, you're going to want to remove anything wet on this individual, get them in dry clothing, insulation, blankets, that best you can. You're going to want to prevent cold heart. So again, especially as you progress further down the continuum of hypothermia, you are increasingly at risk of dysrhythmias. So you want to move them very gently. You want to keep their cardiac irritability as low as you can, and that is going to avoid some of these fatal arrhythmias. Again, a common term for this is cold heart. There are a lot of terms that we're probably going to see today that you've heard before, maybe heard in passing, and maybe now you'll know a little more what they mean. So that is the goal there. You really want to prevent making this individual run, making this individual do anything strenuous, moving them too quickly, increasing their anxiety, things like that. You also want to prevent any comorbid conditions from complicating their recovery. So any comorbid conditions that you are able to identify and address, you want to address those. So if you have somebody who is hypoglycemic or showing hypoglycemic in your secondary, go ahead and give that person oral glucose, because tell you what, they're going to need it while they warm up. And that's what we're going to talk about here on rewarming. Again, like I said earlier, there is a lot of cellular metabolism that happens, not just in hypothermia and frostbite too. We'll see a bit of that. And so if someone is already hypoglycemic, get some sugar in them, okay? So when it comes to rewarming, we have three types of rewarming, kind of similar to how you have your passive, active, and cold immersion, right, with heat. I'm drawing parallels here in case some of us feel a little bit lost. So first is going to be your passive external rewarming. This is going to warm you up at a rate of about 0.5 to 2 degrees Celsius. Definitely should have put these in Fahrenheit, sorry. Best for your mild hypothermia. So taking off wet clothing, putting insulating layers on them to prevent heat loss, and letting them warm passively. Biggest thing that's going to happen with this individual is they're going to be shivering, right? And you want that. So like I said, shivering produces a 5 times increase in heat from baseline spontaneously. But what do you need for this? You need adequate glucose, and you need good oxygen levels, okay? So those are going to be the things that allow your body to shiver and warm you up. It is a great mechanism that we have built in. And for your people who are mild hypothermia, they were just in the cold too long, that is going to be how you can help them and get them back to normal. Next, we have our active external rewarming. So this is going to be necessary for your moderate to severe. You can use heated air units to decrease heat loss and transfer heat to them through convection. You can also place, sorry for the typos, guys, you can also place heat packs on this person's body to facilitate rewarming. So think our typical spots, right? The armpits, chest, back. Water immersion for hypothermia, the research just generally says it's just more cumbersome, and it can be challenging to monitor these individuals and make sure they're rewarming appropriately. So they just pretty generally say you want to stick to a lot of your dry heat. Along with that, if you rewarm them too quickly, you can have vasodilation, right? Which is then going to force cold blood into your circulation, and it's going to increase your cardiac load abruptly, and bam, all of a sudden our cardiac irritability is not low anymore. So we want to be very gentle with these individuals, and they typically are going to just recommend heat packs and hot air, a hot air unit. And then for our severe hypothermia patients, you have active internal rewarming. Again, for field management, obviously this is going to be beyond us. You really just want to monitor these individuals, use active external warming. 911 is already called. Hopefully they'll be able to come in and help with the internal rewarming. So this can be warm intravenous fluids, warm saline lavage of like the pleural cavity is one that they use, hemodialysis, continuous arteriovenous rewarming. So that's going to warm the body up at about 4.5 degrees Celsius per hour. And then you have your extracorporeal methods. So ECMO, cardiopulmonary bypass. That is when you're getting into quick resuscitation and rewarming because of how severe the hypothermia is. They tend to have the best prognosis when you go all the way to that like ECMO side of things. But again, for people who are in cardiac arrest due to hypothermia, their chances of survival are going to be 50% or less. Okay, so, but that's just a little bit of an overview of the methods of rewarming. Again, we're going to be in that passive and active, right? But just be ready to prepare an individual and wait for EMS and let EMS know if you have somebody who is in that profound hypothermia stage, and they'll prep ER because that person's going to have a little bit more of an involved recovery. So that's a bit about hypothermia. Hopefully that's helpful. And now we're going to talk about things that are a little bit more chill. All right. Our localized cold injuries. So we're going to go over 4 main ones. 2 of these are going to be ones you actually really encounter. The other 2 are going to be rare. So pun intended. So frostbite. This is my trigger warning for anyone who is really bad with pictures that are very graphic. This is going to be the best picture you're going to see. It's all downhill from here. Okay. So what is frostbite? Frostbite is the freezing and crystallizing of fluids in the interstitial cellular spaces due to prolonged exposure to freezing temperatures. It says just interstitial, should be interstitial, and also your extrastitial cellular spaces. Is that right? It happens in both. Unlike frostnip, which is on the surface of the skin, this is inside the cells, causes permanent damage to these cells. It is going to be your most common type of freezing injury. Usually your most susceptible zones are going to be hands and feet, and then your exposed tissues, of course. We're thinking of our wind chill, right? Treatment goals, if you have a frostbite patient, are going to be just to salvage as much tissue as possible and supports them being able to return to maximum function and prevent complications. We are typically just going to be dealing with your milder frostbite cases. Everything else is getting referred, okay? So first, we're going to talk a little bit about frostbite pathology, just so that we understand on a deeper level how frostbite occurs, okay? So what happens when your body starts to get cold or is exposed to extreme cold, right? Like I said earlier, you have that vasoconstriction of your arteriovenous anastomoses. So these are going to be those smaller blood vessels. They are going to prioritize your core and they're going to decrease blood flow. So your normal cutaneous flow is going to be 200 to 250 milliliters per minute. At 60 degrees Fahrenheit, at maximum vasoconstriction, you are down to 20 to 50 milliliters per minute. Okay, so that is, you're down by 90% of your typical blood flow. When you go below 60 degrees Fahrenheit, your body starts to do this thing where it has these rhythmic bursts of vasodilation, which occur for 5 to 10 minutes, about 3 to 5 times an hour. This is also known as a hunting response or the hunting reaction, if you've heard that term before. So I don't know if any of you have ever been out in the cold for a really long time, but if you ever have that like kind of throbbing happening, that is your body vasodilating to give you some blood flow to preserve tissue, and then it goes back to that vasoconstriction. That's just kind of its way of helping out. Your acclimated individuals are actually going to have more often these rhythmic bursts versus your less acclimated individuals. But at 50 degrees Fahrenheit, you're going to have neuropraxia. So you're not going to be feeling, you'll have that numbness, right? So neuropraxia, for those of us who aren't familiar, it's just like a mild nerve injury. It causes no permanent damage, okay, and you will recover fine. So if you've ever been outside long enough to where your fingers went completely numb and you could not feel, and then you had that painful rewarming, which we'll talk about later, that's kind of along that sensation. And then at below 32 degrees Fahrenheit, our skin begins to freeze, and without circulation, our blood vessels are going to go through the frostbite injury cascade, okay, which we're going to talk about real quick. It's a 4-phase cascade on the right here. And this cascade is typically going to follow from your smaller blood vessels to your larger blood vessels, and your venous to your arterial blood vessels, okay? So first phase is going to be that pre-freeze phase. Superficial tissue cooling, increased blood viscosity. We're getting a little thicker there. Again, that microvascular constriction, shunting that blood away, ischemia, and you're going to have that plasma leakage. That's actually what leads to the crystallization. Then you have the freeze-thaw phase. This is going to be marked by ice crystal formation. First is going to happen outside the cell before it starts happening inside of the cell. And this extracellular crystal formation is what draws water out of the cells, and you have that osmosis, that osmotic change. So the inside of the cells is going to be a higher concentration because it's pulled water out. And that's how you have freezing outside of the cells before you have it inside. Thawing with these individuals may induce reperfusion injuries, which we'll talk about later. Then if you continue down the cascade, you have the vascular stasis phase. So your body is going to continue to shunt blood away at this kind of margin. You start to have some true tissue damage here. You're still kind of having this alternating constriction and dilation, and that's where you start to have that coagulation and thrombus happening. Again, plasma leakage continues, and then your late progressive phase is going to be really marked by that tissue death and necrosis. The thing that makes frostbite so difficult is that your body is going to continue to try and follow processes it normally follows, which require a lot from cells that are extremely at risk due to this freezing phase they've gone through, and it leads to tissue death rapidly. So that is really why frostbite progresses as bad as it does, and it's why you do not want to warn people that may freeze again, because you're just going to make it 10 times worse, okay? So the pictures are graphic. You have been warned. All right, let's move on. So assessing frostbite. You have good indicators that are showing, okay, we can kind of deal with this, and then you have your bad indicators, okay? So favorable indicators are going to be that it's very superficial, early sensation to a pinprick, the skin looks pretty healthy after you've rewarmed them, and your clear blisters are going to be a lot better than your hemorrhagic blisters. So your clear blisters are going to be more indicative of, you know, this is going to heal normally. There's a lot I can explain of why that happens. We talked about a little bit of it earlier, but basically when you are warming the skin after someone has frostbite, you're going to have this intracellular swelling tissue edema that occurs, which increases compartment pressure, and then you have that thrombosis and bleeding that takes place, because your body is trying to run the course of how it handles cell damage. Your poor indicators is this absence of edema, hemorrhagic blebs. So those are like those dark blisters are going to tell you that this person needs more significant care. Blebs that don't extend to the tips of the phalanges, so they don't go distal. And then mottling or kind of a bluish tinge, especially if you're finding someone who is outside. Anesthesia, they can't feel even after you rewarm. And then, of course, if you see someone who their tissue looks frozen when you're assessing them. Okay, So you've been warned, guys. Graphic. Treating frostbite. Rapid rewarming and circulating water is going to be your best bet. Now, the reason they say rapid rewarming with frostbite is because when you rewarm slowly, you are increasing that damage or that insult that happens to the cells, because as deep blood vessels start to rewarm and your perfusion comes in, if you're rewarming this person very slowly, your tissue is going to have an increased oxygen demand as it warms back up and is going through this kind of cycle of what's damaged, what's going on with it. And you'll have an increased oxygen demand that is not being supported by blood flow. That's why you want to rewarm these individuals quickly, get that blood flow in there so that the tissue has the oxygen it needs to be able to heal, or even identify kind of the borders of what's damaged and go through its kind of whole leukocyte, just the general cascade that we know our tissues go through when there is damage. So we rewarm these individuals quickly and circulating a warm water. Blister management, typically, if they have the clear blisters, we're going to leave them alone. Some literature says to aspirate or debride if it is on a joint or interferes with movement. Just refer these individuals, honestly. If it's not a small blister that they're just leaving alone, refer them out if we think it needs more. Hemorrhagic blisters, they are not going to typically touch those, but we're going to refer those individuals anyway. Frostbite and how severe frostbite is takes a while to determine. If you look on the right there, I've kind of identified the zones of injury. Okay, so your most distal zone is going to be your most irreversible and severe tissue damage. Your zone of stasis is going to be severe tissue damage that's kind of reversible. In this picture, you kind of see that kind of pinkish border. And then your zone of hyperemia is going to be your least damaged tissue. This can take 60 to 90 days to fully run its course and develop. So they're typically going to avoid early debridement or amputation because they're going to want to see what this tissue looks like over time. But if someone has wet gangrene or sepsis or anything like that, they may do it earlier. If you are rewarming someone who has kind of a milder frostbite, you know, they had a better prognosis, those positive indicators more than negative ones, definitely want to administer NSAIDs. If they go out to outside care, they're probably going to give them something stronger. Rewarming frostbite is very painful, as I'm sure we can imagine. Again, like I said earlier, we never want to rewarm a body part if there's any risk of refreezing at all. You're just going to triple the amount of cell damage that is going to occur because, again, it's a very involved process. Frostnip, kind of like the precursor to frostbite. Okay, again, these ice crystals are going to be on the skin surface. Rewarm them with warm water. Probably give them an NSAID for pain and inflammation. They're going to be fine. Pernio or chilblain. So this is a rare inflammatory condition that primarily occurs as a response to damp conditions, often just spontaneously occurs on its own and is acute, but it can be secondary to other health issues. So I kind of have lupus on there, leukemia, acute leukemia is another one that people will develop pernio from. So you really just want to get a good history if they have anything complicated going on, and then get the timing of these lesions. Usually it's a recent cold exposure and they have these kind of little dots, red specks and zones kind of pop up. And when the cold goes away, they get better. So remove them from the cold. Lifestyle changes like smoking cessation, okay, because the mechanism for this, I didn't want to go deep in pathology, but it's like vasospasm is what causes pernio. So your smokers, often recommended they stop if they have chilblains. Sometimes you may need to refer them for a corticosteroid to their GP if that's necessary. Trench foot. If you are dealing with your military populations, this is going to be one that may pop up. Sometimes also maybe some of your utility guys who may work really, really long shifts. So we know some guys who work 24-hour shifts. I've even seen some of those in construction and longer. So this is just exposure to cold temps and in a damp environment. Sometimes also unsanitary conditions can lead to the skin and tissue breaking down. Again, you want to catch this early. If you catch this early where they don't have already open sores or like a strong odor or gangrene present, then it's just drying the area, applying heat packs, keeping it warm and dry, rest and elevation, okay? If that does not resolve it and the skin returns to normal, then go ahead and refer that individual. And if they do have more of those severe symptoms, so open sores, maybe an odor, or you start to see some of that ischemic or necrotic tissue, you're going to go ahead and want to refer that person to wound management, let them help with that. But prevention is the biggest thing when it comes to trench foot. Like, change your socks all the time, regularly, keep them warm and dry. That's going to be what helps that, okay? So our last two slides are just going to talk about prevention and mitigation. So for management, especially on your sites, you want to make sure if you have workers who are, yes, Jeremy, that is a good point. Those can happen in non-freezing temperatures. The last two we talked about, chill blades and trench foot. So if you have workers exposed to extreme cold, you want to always have a dry heated shelter available for them. And even with these workers, you can get into kind of work rest cycles with them if that is necessary or warranted. So do a little homework on that, but definitely want to encourage frequent breaks just to keep them from getting too cold. Buddy system, you do not want these workers alone in the cold, especially just having someone to recognize, like, oh, why are you taking your coat off? Like, it's cold out here, right? And kind of see those early signs of a cold illness. Hazard identification, like I said, with our slips, trips, and falls, management, safety, even you as the on-site can walk areas like ramps, docks, stairs, areas that stay in the shade, don't get sunlight, and may present ice hazards and so on. Really, management should be doing a good job walking and identifying these hazards and mitigating them. And then if necessary, depending on the work that your patients do or your population, your team, they may need to wear specific PPE. I know some places require fleece-lined gloves at certain temperatures or specific levels of clothing. You want a lot of layers, right? They may even need traction devices and things like that if they do know that they're going to be working on ice surfaces and stuff like that. And then when it comes to educating our workers, a couple things here. One, use the COLD acronym for getting dressed. So that is going to say your clothing should be clean. It should avoid overheating, so you should have multiple layers on there so that if you are exerting yourself, you can remove some of those layers because you don't want to get damp in your clothes. That will result in losing heat. You want loose layers so that they can trap air, not compressed layers, because trapped warm air will facilitate circulation better. And then you want your clothing dry. So if anything gets damp or wet, you want to immediately change that into something dry. And then you want your workers to arrive rested. Like I said, shivering takes a lot of energy. So you need to be rested so your body can do what it does to keep your core temperature where it needs to be. And you want to prioritize sleep and recovery when you're working in the cold weather, again, to help your body when it's responding to those temperatures. And then you want to be hydrated. Again, we learned a lot about the pathology and kind of the physiology with vasoconstriction and how our body mitigates core versus peripheral temps. So hydration is going to make it a lot easier for your body to be able to keep you nice and warm. So that's definitely the kind of education at minimum we want to make sure our workers are getting. And then obviously any weather forecast or specific site-specific data you might have, sharing that with your workers. So hopefully that was helpful. Hopefully you feel prepared to be out there with your workers in the cold. And I will take any questions if I can answer them. I'll do my best.
This one's more for a group, but I'm curious on organization, job rotation plans for either being out in the environment or being out in coolers or refrigerators or anything else like that? Does anyone currently have job rotation plans?
Silence.
When
Well,
I worked at a ice cream facility, for anyone working in the deep freezer, it was 15 minutes in, 15 minutes out, rotating that way.
and did you have a buddy system or like a way
Yep, always at least two people. And they were in full winter gear, gloves, boots, insulated pants and jacket and hat and everything.
Nice. And then for construction folks, are there like no-go on like months that you can't be outside?
We never had any, at least when I was in Virginia. I mean, San Antonio, if it's below 35, no one's doing anything. Let's be honest. They're just not showing up. I'm sorry. But
we never did up in Michigan, even when it's below 0, they never had any modifications to if they could be outside or not.
Yeah, that's interesting that we have all these heat-related illness protocols, but we're the cold, like, gear and potential job rotations. But be curious if that's something that we can always be working with. Jeremy, we are working with our safety departments to develop an exposure-based rewarming plan. Yeah, that'd be huge too, right? The rewarming plan and trying to make sure that we don't do anything negative for the tissue, right? A lot of us are probably good at like all of our fingers and everything when we're wearing gloves, but is there any like skin exposure, like our cheeks or our nose or something like that might be considered? Like I remember when I grew up in Michigan and I went down to North Carolina, people made fun of me because I had scarves. And I'm like, hey, like it's cold. Like you try like breathing in negative 17-degree weather trying to walk to class, right?
Mm-hmm.
It's not great.
I mean, I do the whole like balaclava. You will see my eyes only because I can't do it. Jill said if specific work could be scheduled differently, that was how they modified it. For example, they'd schedule certain maintenance for a different day when wind chill isn't as bad. And that's kind of what I saw in Virginia too. Like we would definitely have days where we were like, this is pointless, people being out here. It's so cold. But they would always attempt, right? Typically what meters them is the workers just don't show up. They're like, that's not worth it. Often because getting to work is already going to be a problem. I would definitely be interested in your like South Dakota, North Dakota people who live at work and a lot of your oil field guys who are already there, how they help them manage just because they're more likely to come to work. But I know in Virginia, we had like kerosene heaters outside that the guys could like stand near and get dry heat. Oh, the CU link is right here. And yeah, we'll email it out. Right? Like,
I can do that. Yeah.
Okay. The CU link is right there, guys, if you haven't clicked it and claimed your CU yet. But yeah, we'd have dry heat from kerosene heaters that the guys could use. And you would see them take their gloves off and like put their fingers up to it and stuff, you know. But you would think I had hypothermia if that was me, because I'd be taking off my boots. I'd be like throwing my toes up there. Like it'd be a problem because like I get so cold. Yeah. Cool. Did anyone have any questions for me?
I just liked how you talked about, I feel like sometimes in movies or whatever, people are dramatic and they're like, okay, make sure you slowly like warm them up because it's going to hurt. But what you said just makes like, total sense of your tissue has certain needs, like caloric wise, and then obviously oxygen, like recirculating everything. So with it getting warmer, like you add in the general component of it just being tissue. So it's like, all right, we're just going to go dump them in a hot vat somewhere and they'll be fine.
Yeah.
Better than like, that's so funny.
Yeah, I would say like frostnip for sure. You can just like get that person dry, and I definitely recommend just letting that warm up, right? Frostbite, again, you definitely don't want hot water on there, like you said, but definitely there's a certain speed at which you want, which was very interesting to learn. And that's truly what I was learning was that tissue has a lot of demands from when it goes from frozen to no longer frozen, and those demands go like jump up very quickly. And if you don't have the blood flow to meet those demands, you can definitely have a lot of ischemic insult to that tissue. And you want to avoid that with someone who has frostbite. They're already going to have a bad enough day. So sometimes it's better to just give them some meds and be like, this is going to hurt, but we can't spend an hour and a half doing this.
You want to lose it? No? Okay.
Right, exactly. So you kind of got to just get that going. Yeah. Heated jacket, heated gloves, heated hats. Jack said, yes, I will add the caveat there. We did have several reports last winter of workers with the heated insoles catching on fire. They had a worker with third-degree burns at a construction project who had heated insoles that caught on fire. So that could be its own CU thing, like all the tech and gadgets and how they pose their own concerns in any temperature or weather. But definitely watch your people who are using the heated things, your lithium battery jackets, and some of your other heated things. Just definitely look up any recalls, get it from a reputable brand. Don't use chargers you're not supposed to use with it. Please don't catch on fire. It's a bad experience, especially when it's your foot, because you probably need that. So yeah, we had a case of that.
Wonderful. I'll go ahead and stop the recording.
This concludes the IATS On Demand Continuing Education Program video. To claim your CU, you must be a member of the Industrial Athletic Trainers Society and complete the From Claim Your CU found in the YouTube description. If you have any interest in learning more about what the Education Committee has to offer, reach out to the email address on your screen. If you would like to volunteer your time to speak on a topic that interests you, please reach out. Thank you and stay safe.